As Dr. C.B. Patil concluded, any chronic coronary syndrome can become an acute coronary syndrome anytime. Now let's learn how to manage these patients from a very popular set of cardiologists. May I request chairpersons for the next sessions, Dr. S.S. Ramesh, Professor Nagaraj Desai, and Dr. Sunil Bohra to come to the dais and take over the proceedings.
Good morning. As I said, we are coming to an important part where at least the controversies are less. Definitely in acute coronary syndrome, the interventions have really saved a lot of lives, and definitely patients can look forward to a better prognosis. So let us hear from two senior cardiologists about the present concepts on management of coronary infarction and dual antiplatelet therapy. In the beginning, I request Dr. R. Keshava, head of the Department of Cardiology at Manipal Hospital, Airport Road, to speak on emerging thoughts on the focus of 2025 ESC AHA guidelines.
Good morning. At the outset, I would like to thank Dr. Desai and Dr. Prabhakar for this opportunity. 7 years is a great achievement. I think it has many more years of good educational knowledge spreading for the next few years. This is a 2025 guidelines. European Society, the last guidelines was 2023. So what is new? I think many of us are already practicing, but now it's come into guidelines, so we are more confident about using this. The top take-home message is inpatient dual antiplatelet therapy for all ACS patients. The important word here is about ticagrelor and prasugrel is recommended in preference to clopidogrel. So all of us were taught that if you have ACS, give 8 tablets of clopidogrel. Now you are justified in saying that give 60 mg of prasugrel or 2 tablet of ticagrelor. We are justified, and this is come in the guidelines. Now in patient with non-ST elevation ACS also, invasive strategy, you can do it after 24 hours after upstream therapy. So that means that if you have unstable engine and RQMI, you can refer the patient for a procedure up to 24 hours. Suppose you get a patient at night 10 o'clock, should I do the angiogram at night 10 o'clock only for a ACS unstable angina and RQMI? No, I can wait up to 24 hours to do the procedure. Suppose you are in a patient nursing home, you can manage the patient, ship the patient, and the next day within 24 hours for this procedure. Now here the next question is, once you start at EAPT, how long you want to continue? 12 months is the default strategy for all patients with ACS without high bleeding risk. Three important things that has come is, if the patient has a high bleeding risk, if the patient bleeds, aspirin can be withheld. You see the point A. In patient with the risk of GI bleeding, proton pump inhibitors are recommended. This is the first time they said that proton pump can be used in patients with this one. And in patient with dual antiplatelet therapy, after 1 month you can change it to single antiplatelet therapy involving or excluding aspirin. So all of us were taught that aspirin is for lifelong therapy. Now we have come to a stage that in ACS, if a patient has a high bleeding risk, or if the patient you feel that he has a GI problem and all, you can withdraw the aspirin at 1 month and continue only ticagrelor or prasugrel beyond beyond 1 month. In patient who require long-term anticoagulation, aspirin is discontinued after 1 to 4 weeks after PCA treatment. So now we have come to a stage where aspirin was a god for all of us for so many years. We are thinking that now God can also be withdrawn for a few months or can be stopped after a few months. So all of us thought that aspirin is a gold standard. If you don't use, you are in a legal problem. It reduces mortality. Now we are also thinking that long-term continuation of aspirin can give rise to complications. After DAPT for 1 month, if you think that the patient has a high bleeding risk, you can withdraw aspirin. That's the important take-home message. Now the next important statement is about LDL therapy. Important word here is about 70 milligrams. 70 milligram, this one, and when you start the patient on ACS, you start the lipid hydrostatin therapy, wait for 4 to 8 weeks. At the end of 4 to 8 weeks, if the LDL is not less than 70, you can start on ezetimibe, you can start on evolocumab, alifurumab, inclisiran, bempedoic acid. So, and if it's reasonable for high risk population to intensify the LDL to 55 to 70. This is about American guidelines. Indian guidelines have gone further low. So that means that if you have a multiple stents, high risk patient, you are not meeting the target. Target is 70. If you are not meeting 70, add ezetimibe, very cheap. Then evolocumab, inclisiran, bempedoic acid, all of them are there. And in a very high risk patient, your target should be 55. Now, the next question is about interventions. Any unstable angina, high risk group and non-high risk group. High risk group, invasive therapy is definitely needed within 24 hours. Non-high risk group or a low risk ischemic patient, routine invasive or selective invasive approach after risk stratification. Suppose patient comes with chest pain, troponin is negative, ECG mildly positive, ECG is mild changes, you can subclassify him as a low risk group and you can further risk stratify him and then continue for an invasive procedure. They have come out with 2 guidelines. Radial approach is preferred over femoral approach, and intracoronary imaging is recommended to guide PCA in all patients with ACS with complex lesion. There is an important statement that intracoronary imaging reduces mortality. Radial approach is preferred over the femoral approach. Now the important, another one thing is complete or staged revascularization. Complete means if you have a multiple lesions in ACS, do the complete, open up all the multiple stents, or staged revascularization, whether you can do it after some time. After some time, the word is 45 days, whether you can do within 45 days. So, in a single procedure, you can do if the patient is not in shock, if the patient is in lost treatment. In patient with ACS with shock, emergency revascularization of only culprit vessel is indicated. Routine PCF, non-culprit vessel is not indicated. So, that is the important word. In ACS, not shock, you can do the complete revascularization. With shock, only the culprit vessel should be done. Now the next statement is about role of LV assist device, Impella, microaxial flow pump. It is important in cardiogenic shock with acute MI. Impella reduces mortality. However, there are complications like bleeding, limb ischemia, and renal failure much higher. Therefore, careful attention of vascular approach and weaning of support is needed. So this is the first time they have come out with the LV assist device. Another important statement, blood transfusion in acute MI. 10 grams if the hemoglobin is less than 10 grams in acute MI, ACS, acute and chronic anemia, blood transfusion can be done if the hemoglobin is less than 10 grams per cent. Post-discharge, what are the change in the guidelines? 4 to 8 weeks after starting lipid therapy, reassess the lipid lowering therapy efficacy. Cardiac rehabilitation already has been discussed. Home-based program to facilitate patient recovery faster is encouraged. So the important take-home message is target is LDL. If LDL is more than 70, add a non-statin lipid lowering agent. Level of evidence is 1. Class of evidence is class 1. If it is between 55 to 70, non-statin therapy is reasonable. That is class 2A recommendation. So, this is actually more or less repeat of what is the old and what is the new therapy. And this is 2000 up to 2021 guidelines. This is 2025 guidelines. If you see that LDL target should be, if it's more than 70, add non-statin lipid lowering agent. Most of us use ezetimibe. And then if it's not controlled, we add bempedoic acid. If it's not controlled, we'll then start thinking of evolocumab or inclisiran. And class 2A, 55 to 70, it is class 2A. And revascularization, I think take-home message is multivessel disease, no shock, complete revascularization. Shock, if you see class 3, in patient who is STEMI complicated by shock, routine PCA of non-infected artery should not be performed because of higher risk of death and heart failure. So important thing is shock, do not do the non-culprit vessel. And this is again the same. And DAPT duration, here the important word is inpatient ACS who are at high bleeding risk, DAPT with aspirin P212 for 1 year. And here you see that unstable angina, prasugrel and ticagrelor are both recommended. This is the first time prasugrel has also come into the treatment, and their class of evidence 1. Now, what is the difference between European and American guidelines? European guidelines is 2023, American guidelines is 2025. And here you see that European guidelines were already at 55. LDL levels were at 55 in patients with ACS, but American guidelines is at 70. So, I think Indian guidelines is also at 50. And adding non-statin therapy between 55 to 69, ezetimibe role has been emphasized again and again. And that is about ezetimibe. Revascularization, again, there is no much difference. Cardiogenic shock, non-infected artery should not be touched. And then, if there is no shock, complete revascularization can be done. So that is again telling the European and American guidelines. DAPT duration, again, emphasis is on 1 year, and prasugrel ticagrelor has come into picture to reduce the events, and stent thrombosis rates also will come down. And the important thing is switch to monotherapy after 1 month to reduce the bleeding complications. This is an important step, that we need not continue aspirin for a longer therapy. And de-escalation, if you see class 2B ACS, de-escalation, switching ticagrelor prasugrel to clopidogrel after 1 month may be reasonable if you have a bleeding risk. So that's also important statement, that how to adjust the dosage. And 1 or 2 words about triple therapy. If you want to combine anticoagulant, aspirin, ticagrelor with Novax, after 1 to 4 weeks, discontinue the aspirin and continue only clopidogrel with Novax to reduce the bleeding complications. So triple therapy, notorious for bleeding complications. And again, emphasizing that 1 to 4 weeks later, aspirin should be stopped in a high, if you want to combine a Novax, and downgrade ticagrelor to preferably clopidogrel and add a Novax. These are all the few change in the guidelines, and with that, otherwise majority of the guidelines remains the same. Thank you.
Thank you, Keshava. I think we'll take the questions at the end of the session.